Good morning. I'm Nora Yurig. I'm the Director of Neuro, Ortho, and Pulmonary over at Broward Health North. I'm also a certified neuroscience registered nurse, and I've been with Broward Health North almost 20 years. And so what we're going to talk about is Parkinson's disease, basically going into the basics, things that you would be interested in. So some of our goals for today's presentation is we're going to define what is Parkinson's disease. We're going to look at what the signs and symptoms of this disease is. There's both non-motor symptoms, and then there's motor symptoms that go with the disease. So, you know, there are no boundaries with Parkinson's disease. So there's many faces that come with this. And as you can see, when you look at the screen, these are some celebrities that actually have had Parkinson's disease. I think everybody's very familiar with Michael J. Fox. Michael J. Fox, when he was diagnosed with Parkinson's disease, his symptoms was more of twitching of his fingers and having shoulder pain. And he really did not reveal that he had Parkinson's disease until he got further into the disease process. And then we have Pope Paul II, and he also was diagnosed in 2005, and his symptoms started out as having some of the classic symptoms of Parkinson's disease, which was tremors and stiffness. And then I think a lot of people are familiar with Janet Reno. She was a former attorney, a state attorney, and she was diagnosed with Parkinson's disease. Her symptoms were more of the rigidity and the tremors also. She was diagnosed when she was only 57 years old, and unfortunately, she passed away from the disease in 1963. So then we have others. We have Johnny Cash, and we have Robin Williams over here. And so you can see that there's no boundaries with this. So, and it's not uncommon. So if you look at the green chart up here, it shows that 1 in every 100 people over the age of 60 in the United States has been diagnosed with Parkinson's disease. 60,000 new cases will be diagnosed this year. And then in the United States, there are about 1 million individuals with Parkinson's disease, and 5 million worldwide, and that's pretty significant. So what is Parkinson's disease? So we're going to talk about it's a neurodegenerative disorder, and it affects the body's ability to move fluidly. So what that means is to move just as it should be, like flow correctly. So with the motor symptoms and the non-motor symptoms, this creates an issue with the body's ability to do this. And again, we said motor symptoms, non-motor symptoms, and we're going to go ahead and we'll talk about what each of those are. And it's also a dopamine dysfunction in the brain. So when we talk about neurodegenerative disease, well, let me give you a little bit of history first. So if you look at the right-hand side, you can see this is the history of it. It was first mentioned in 1000 BC, but there was an English doctor, James Parkinson, and in 1817, he described the classic symptoms of Parkinson's disease. And it was characterized by the rigidity, the tremors, and then the dyskinesia, which we'll talk about, which is just the slowing of the movement. So as you can see, Parkinson's has been around for a long time. So this is how it came to term with the name of Parkinson's disease. So Neurodegenerative disorder is where cells of the central nervous system don't operate the way that they should. They quit working. And they say that it's mostly due to either genetic or to environmental reasons. So when we talk about motor symptoms, you can see, and we'll go further into like the stooped posture, mask-like symptoms, the rigidity, the hips and knees are just slightly flexed, and you have that shuffling in your steps. So they have bradykinesia, tremor, rigidity, and then you have postural instability. And with that posture, of course, with the instability and the rest of these symptoms, then these patients are a really high risk for falling. So let's talk about bradykinesia, which means slow movement. And this is the defining feature of what Parkinson's disease is. It's often described as weakness, clumsiness, and incoordination. And some of the ways that it affects an individual with their voluntary automated movements is through the walking. Again, it could be the shuffling of the feet, the slowness. Also with writing, or even just eating with your spoon, pulling your spoon up. Again, it's going to show slow movement. And also as simple things as brushing your teeth. So some other things. So what happens with bradykinesia is that the muscles come to a point where they just stop working. They immobilize. I'm not sure if you ever heard, but what one of the things is that you will see individuals that have Parkinson's disease, they have that slow shuffle, but then they may actually come to a freeze in their movement and just stop and stand there. And then you also may see then all at once they do quick movements, moving forward, almost like an impulse type of thing. So as far as tremors in Parkinson's disease, it usually starts either in one hand or one leg. And of course, in the your prominent hand, it's very troublesome because this is your dominant hand is the one that you're using. And it's when you go to do something too, you will see not just at rest, the tremor, but also you can see it when you're doing an action with that. And of course, this, you can see how this would create disturbance in your sleep. It almost would be like people who have, whatever I want to say, the spasms in their legs when they sleep. So the second classic sign, so the first one was dyskinesia, which is the slow movement. The second one is rigidity, stiffness, and things like just putting on your pants or reaching across the other side of your body is very difficult to do. Getting in and out of a car becomes difficult, or just in bed when you're lying there and you decide to repositioning, just being able to turn over because of the stiffness that is going on. So again, there's gait dynamics, gait problems going on. You can see in this picture here, this gentleman has the stoop posture. You have a reduced arm swing, and that means that it stays closer to your sides and doesn't, you know how when you're walking, usually I'm a person who walks and my hands are flying. So these people actually keep their hands are actually reduced with swinging. And then you'll have that shuffling walk. Sometimes you will see an individual who will drag one foot, or they actually could be dragging both feet. And we talked about how they can freeze right into their movement when they're going. And then again, that unwanted, that acceleration where all at once, so they freeze and they're there, and then all at once they move quickly. And again, the postural instability again, can create falls. So again, these people are real high risk. And with this also, you could have tremor, or maybe you don't have tremors going on. So some other motor symptoms is dystonia. And this is like where you can have some cramping and posturing. Like an example they're using is in your feet. And you can see right here on the right where the person's foot is actually posturing and cramping. It also can twist, and it actually is painful when this actually happens. And you cannot control this when this goes on. Then other motor symptoms, is dyskinesia. This is uncontrolled, involuntary movement, and it's commonly regarded as like wiggling, your head bobbing, uncontrolled, and fidgeting. And Michael J. Fox was actually had dyskinesia. You could see sometimes in his presentations and stuff, the bobbling of his head with the involuntary movement. So then you have other non-motor symptoms, and you're going to think, well, you know, these symptoms too contribute to other disease processes, and it is true. But with the non-motor symptoms, you're going to have a loss of sense of smell. You could have, and these are all you could. Constipation, REM sleep disorder, and this is rapid eye movement, where you could have this going on while you're trying to sleep, and you don't go into that deep sleep. And anxiety and depression is huge with Parkinson's disease. There can be mood changes. Again, we talked about where someone just accelerates in their walk. I mean, they can become very impulsive. They can also be apathetic, where they're just not really doing anything, and fatigue. And then you could have changes, of course, in your bladder habits. And what I was talking about with the dystonia was where you get the cramping of the foot. It is just almost similar to the restless leg syndrome type of things, and it'll awaken you at night, and you have no control over this. Other cognitive issues is memory difficulties. You will have some slow thinking going on, and possibly some confusion going on. You could have some vision changes, and orthostatic hypertension. So what that means is that, like when you get up from a sitting position, or if you're in bed and you go to get up, then your blood pressure actually drops. It's what's going on within your equilibrium of your body. So an important thing to do is, if you go from a lying to a sitting position, is to make sure that you just sit there like 1 or 2 minutes, so everything can just come together, because this actually could create is a high risk fall too. There could be sexual problems involved, and drooling, and I think the drooling is pretty significant. And then you can have some skin changes, as where you lose more of the elasticity of your skin, and you can have excessive sweating. And again, some of these symptoms that you have, like the dystonia, can create pain. So what causes, we're not going to get deep into this, because I'm going to just tell you exactly what it is, what Parkinson's disease is. So Parkinson's disease is where, I'll point to the one area, is the loss of nerve cells in the part of the brain that's called the substantia nigra. And this part of it, this is deep into the brain. And it's also caused by low dopamine levels. And you'll see this all the time in a Parkinson's disease individual. This dopamine is responsible for relaying messages that plan the plan and control movement. These nerve cells are responsible for providing this. It's a chemical. Dopamine is a chemical. So you have low levels of dopamine in your body. You could have, mostly you do have. And again, it affects the substantia nigra, which is deep into the brain. So here's the hypothesis as far as the stages of Parkinson's disease. So they say in stage 1 and 2 is more of an autonomic and an olfactory disturbances. And olfactory is smell. And so this would be in the first, and you can see here where it's impacting that area. In stages 3 and 4, you have not only the 1 and 2, but then you start having the sleep and then the motor disturbances, whether it's voluntary movement or non-voluntary movement. So then you can see as you look up at this image here, where it goes up and goes farther into the area and then over in here and up to here. Then you add on stage 5 and 6, and this is where you can have the emotional and cognitive disturbances. And so see, you can now see where it's taken over the majority of your brain. And so this is where you could have the mood swings that are going on, the thinking, the memory. And this is when you usually see this when it's really advanced Parkinson's disease. And when you go to see a neurologist, they will usually stage what stage an individual is in, so they can follow the progression of this disease with the patient. So how does the doctor make the diagnosis of Parkinson's disease? Well, the first thing, the diagnosis is made basically on clinical examination. They take a history. They're looking for that bradykinesia, which is the slowing of movement, the rigidity, and then the tremors. And so they're going to take a history wanting to look at not only do these symptoms exist, but how long have they existed. You could have all 3 of them. You may have just one of them at that time. So they could do a MRI, but usually they won't do an MRI. There are some that they will order the MRI if the person is presenting with these atypical signs, not the bradykinesia, the rigidity and tremors, but there's something there in the clinical examination that the physician is thinking, I think that it potentially could. But if an MRI is done, usually that MRI will be negative and does not show anything. It'll be a normal. And then there's genetic testing that's offered out there, but it offers limited information. But I do know that they will do some, and we're moving more towards the genetic testing. And so it can be beneficial in the young person who is being diagnosed with Parkinson's. For some reason, I'm wanting to say Alzheimer's. So the treatment of Parkinson's disease, you want to treat the symptoms, okay? And you treat the symptoms by either directly or indirectly compensating for the loss of the dopamine. Remember, dopamine is what directs and plans your muscle movement. So different medications the doctor could put you on is the levodopa, which is Sentiment by most or Maripax, and then exercise too. What they want to do though is really modify the progression of the disease that's going on. They want to slow that ongoing loss of those dopamine producing brain cells. And so they're doing that through different things, which we'll go in just a minute, but through some medications, exercise, and other things. And then there's neuroprotective agents out there, and those prevent the loss of the dopaminergic neurons that are involved in this. So one of the things that a person who has Parkinson's disease, their physician will, well, most physicians will share this at any time you go to their office, but you need to exercise because you're having those tremors, the rigidity, and the slow movement. You need to be doing exercise, and it improves also your heart and then also your bone health. So it also will improve the coordination, your gait, your balance, the stiffness, and it also will improve mood, sleep, and lessen constipation. Same thing as if you went to your physician for something and they would say, you tell them, you know, I can't sleep at night. He's going to tell you, you know what, you need to exercise. Just go out and take a nice walk before that. So exercise is huge in management of Parkinson's disease. But there are a couple of different exercises that there has been some research and some articles written about, and that is yoga and Tai Chi. And this helps with balance. And then dancing, which will help improve coordination. And then boxing, swimming, cycling, and golf. But the best exercise that you can do is one that you're going to continue with. It's one that you want to do and that you're not just being told you should do this. Because the more that you are involved in it, the more likely you're going to be successful in that. So I know that the yoga and the Tai Chi are real big at this time with the exercise, and not just in Parkinson's disease, but in overall health. So some of the things that have to be considered. So if an individual has Parkinson's disease, I would recommend that not just that they see a neurologist, but they need to be seeing a neurologist whose subspecialty is in Parkinson's disease to help with the management of that. The person's plan needs to be individualized. What might work for one individual with Parkinson's disease doesn't work for the next one. So the physician, as well as rehab, everything needs to be individual so that you can meet your optimal wellness with Parkinson's disease. So the plan is goal-driven. You've got to be able to measure that you're actually achieving it. It minimizes falls and other health risks. But then you have to start thinking about the costs and transportation and stuff. Can I get to this? Do I have the finances to be able to do this? And there's a lot of support out there through the Parkinson's Association. At one point, the Parkinson's Association actually was housed inside Broward Health North. And then they made the decision that they really should be centrally located out into the community to serve more individuals. And so I believe that their office is still located on West Commercial Boulevard. But then also you need to take in, the physician needs to take in the age of the patient. What are their social dynamics? What do they want to do, enjoy? And a lot of times this information will not just come from the patient, but it also comes from the caregiver. So the physician, or if it's the rehabilitation services, they will not only work with the individual with Parkinson's disease, but will be working with the caregiver. And then again, medication issues. Sometimes you get started on medications. You have side effects from the medications. And so there's a balance with that. trying to get you to the level of what you need to be on the medication. And maybe at some point we need to change that medication. But the most important thing is don't stop taking that medication without your physician's knowledge for him to say, stop taking it. So that's really important. And then again, monitoring those non-motor symptoms, which I believe there was probably about 20 of those different things there. And then if there's any advanced therapies out there, and one of the advanced therapies, it's been going on for a while, but it's deep brain stimulation. And at one point back in I'm going to say 2005, 2006, we actually had a physician, Dr. Thomas Hammond, who was a neurologist on staff, and actually they performed the deep brain stimulation. At this time, though, that we don't do that here, although that we are moving towards advancing our neuroscience program, and that is one of the treatments that is out there on the table. And again, timing of the therapy is important. A lot of times, early morning's not good. And so it's more, they like more towards the afternoon. It's difficult for them to get out of bed. So we got to look at when the time of therapy is. And rehab services is integral, you know, your physical therapy, your occupational therapy, which the occupational therapy helps you with your activities of daily living. And then having a strong social support system makes a lot of difference with that. So some of the things that's going on, there are clinical trial opportunities, and the neurologists are aware of the different trials that are going on in the area. There's lots of education and exercise support groups and resources on excuse me, the Parkinson's Foundation website, which I've put here. But if you just go into the website, into the internet, and if you just type in, you don't even know the actual where the site is, Parkinson's disease, you're going to get hundreds and hundreds of hits on Parkinson's, what it is. But again, it's important that your doctor is providing education and information for you also with on the Parkinson's disease. So that is the end of my presentation. So if we have any questions, we can open it up for that. Open it up. Let me find out how I can open this quickly.
Thank you very much, Nora. I think if you stop sharing screen, it'll just go back to, or if you just want to leave the screen share on in case anyone has questions.
Perfect.
Sure.
So I'm going to say stop share. There we go.
Perfect.
And let me get rid of this. And then
I'll spotlight you here. We have our first question. It says, do genetics come into the mix?
Do genetics?
Yes.
Yes. So that is one of the two major factors with Parkinson's disease, that they say it is genetic or environmental with that. And that's usually, you will see that into the diagnosis of Parkinson's disease. So there can be a genetic component. So one of the things that you can do is what we saw earlier in the power presentation was that talk to your doctor, your neurologist, and see, you know, if genetic testing is something for you.
A question from Regina said, voice changes, info please.
Well, there can be voice changes, and that's due to the tremor that's going on. It doesn't just affect your hands or your legs. It can actually affect your vocal, of course, with that too. And again, also with that, remember, if you got that dyskinesia going on, so things are slowing down, and so that's going to affect that also when you're talking. Any other questions?
Yeah, for those that joined that may have not heard my announcement, if you do have questions, feel free to type them in the chat. The chat is found on the bottom of the screen. And a little chat window will pop up. Or if you'd like to unmute yourselves, I'm okay with that as well.
Hi, I asked the voice changes and what type of therapies are there for that?
Well, actually, besides, remember we talked about rehabilitation services like physical therapy, occupational therapy, but there's also speech therapy. So one of the things that I would do then is speak with your neurologist and see if he could give you a referral to see on an outpatient side to see a speech therapist, because they will do a complete assessment, workup, and testing to see if there's anything that they can do to improve the voice.
And swallowing.
And swallowing, well, and they do swallowing tests too to make sure that you don't have to, you're not at risk to aspirate with that.
Okay.
What about numbness in the legs or the feet? Is that common?
Well, you can have some numbness in things. It's not a classic sign. More of the, it's the dystonia where you have the posturing of the feet with that. And then just not being able, like the dyskinesia or slow movement, being able to reposition and stuff like that. But probably it could, if it, if it's just discomfort versus pain, that's a difference. So if you're actually having pain, then again, I would discuss that with your doctor, because there's no need for you to be in pain with this. Discomfort might be there, but not pain.
Nora, Beverly asked, what do you think of the LSVT, Lee Silverman voice therapy?
The what?
Lee Silverman voice therapy.
Actually, I'm not familiar with that.
Okay. And then Lydia asked, where do I start? I don't know if you want to elaborate a little bit more, Lydia.
Lydia, we'll start with what?
Feel free to unmute yourself as well if that's easier.
I'm really doing this for my husband, and we did tune in late, so if this is repetitious, I'm sorry.
It's okay.
He doesn't know where to start to get the best kind of treatment and the best result. And
okay, so the question is, where do I start to get treatment for Parkinson's disease, or to get diagnosed?
Good question.
With Parkinson's?
Mm-hmm.
Is that the question?
Yeah, that's a good question. Where do you start?
Yeah, well,
okay. So again, I would recommend that not just see a neurologist, but make sure that that neurologist has a subspecialty in treating Parkinson's.
Where do I find
What that means, subspecialty, is that they actually did a fellowship into this disease. And that's like the part of neurology that they focus on and that they really like. And so they stay up on research and all the other modalities with that.
Do I find a neurologist like this? Dan will get this for me?
Yeah. Anything else?
Any other questions?
I don't know what to do. You tell your husband's baffled.
I'd like to say something.
Yes.
Okay.
Where do I
I'm a-
start?
I actually am a speech language pathologist, but I've been involved in this Lee Silverman, as I say, voice therapy and movement, and it's called LSVT big and LSVT loud, and you can look it up on the web, and you can see some of the, as I say, suggestions. And if there's a program, it usually, as I say, is given through either a hospital, a clinic. Okay, and many times it's available free of charge. So I would suggest, as I say, that you look this up on the web, and you can find some good suggestions to do at home as well. That's, as I say, I put that forward.
So in summary, what they're saying is that you can go onto the website, onto the internet, and look it up, and it will tell you information on that. Am I correct?
Yes, yes, yeah. And it's called LSVT.
And actually, I'm going to go on the web and look it
Yeah,
up.
and look it up. LSVT big, LSVT loud. It's with occupational therapists and speech pathologists. And, okay.
You can get a lot of good information from the Parkinson's Association.
Mhm.
They
Yes.
sent them very easy to read, like in individual cards. And it was very easy to get. It takes a while to get it, but they do send it out.
Mhm.
If I can,
And I believe the Broward County Parkinson's Association is out on commercial, but again, they, as someone just said, if you go onto their website, there's lots and lots of information. And then you also can contact them to ask them to send you specific information that you're looking for.
could I ask a question?
Yes.
I'm a veteran and I've just been diagnosed with Parkinson's about a year and a half ago. I started the medication, plus I'm having a big problem with the anxiety, which I see, through your presentation is a big part of it. I'm in Florida now. I live in New York, and I'm going back to New York now. When I go back, they're looking to start a procedure or a treatment with magnetic. I don't know the name of it, but it's a 6-week program where they put it's not like shock therapy, but there's something else that they put on your head, and
Magnetic
it's
resonance.
done with magnets. If anybody has some any information about that.
Yeah.
Actually, we don't do any of that here. However, that is an advanced treatment. So again, you can find that information on the internet.
Now, how severe is the the anxiety is starting
Well,
to.
anxiety is one of those non-motor symptoms that go on. So your neurologist should be taking care of that anxiety also. So whether it's going to be through medication, or he's going to recommend that you exercise or get involved with something. But again, that is something, when we talked about the individual plan of care for a person, that needs to be, if that is a problem, it needs to be involved in your plan.
Well,
Yes.
I did get involved with a rock steady boxing program that I can do on Zoom from Brooklyn, New York. And I can get it on.
Since we've had the pandemic, you basically can go on the internet with Zoom and stuff, or what's it called, YouTube, and find about anything that you're looking for. A lot of home exercise programs going on through Zoom. Yes.
I haven't been seeing much of the doctors, but since I'm down in Florida, at least I can go out and swim and bike and walk and do the exercises and stuff. And so it's abating it a bit, but it's just not doing anything for the anxiety.
Right,
the
no.
decision making.
So, currently, I'm gonna say that you aren't taking anything for anxiety.
Yes, my therapist in the VA, I also suffer from PTSD, and they put me on a fluoxetine and a clonazepam, very low doses.
But it's not working for you. It's not controlling the anxiety.
It's not really working as well as I would like.
So
I have a-
that's why it's important, you know, to share that information with your doctor and say, hey, we're doing this, I'm on this and this, but I'm still having the anxiety. What else can we put in place? And I don't know, do you have a neurologist down here in Florida when you come down in Florida, or just the one in New York?
We need one.
Just the one in New York, and I speak to a psychologist every week from the VA, who I was, you know, is dealing with the anxiety, and also the nurse practitioner who takes over the group that I'm in, the PTSD group. She's able to prescribe, and she was able to give me a couple, but they don't want to change anything until I get back. So I have to, you know, I have to put myself into this full. I've been just trying to do the exercises twice a week.
When are you going back to New York? Is it shortly or?
In 2 weeks.
Oh, okay. Okay. So, but that would be one of the first things that I would do is and you actually could do it now. You could call and get set up with your a doctor in New York. And, you know, now they're doing telehealth. So that might be an option. But if you wait the 2 weeks, then go ahead and that's one of the most, that's important that you actually make contact with them. And just tell them it's not working. I'm still having the anxiety. Yes.
Is there any way okay. Is there any way to get in touch with someone down here? I don't know, through the VA or through the private.
Well, what I could do, if I get your email address, I could look up and try to get some information for a contact at the VA down here.
Well, I'm closest to the facility that I'm closest to is West Palm.
Okay.
So I would like to come someplace closer, but
I think that's the only one I'm aware of too, though, in this area.
yeah. Okay, more than likely I'll wait till I get home to just try and use the medication as I get more stressful situations. The anxiety gets a little worse, but I'll let everybody else talk now. I'm sorry.
Of course. No, you're fine. Thank you. Great questions. Yes.
Where do I start?
Where do you start?
Yes, what's the first thing I should be doing? I've been diagnosed with Parkinson's. What do I do?
The first thing you would do is make an appointment with a neurologist, again, who has that subspecialty in Parkinson's disease. You can go to a general neurologist, but again, a person who has the subspecialty in Parkinson keeps up on the research. They know it, you know, without actually probably thinking of the management, and they've seen so much with individuals. So again, a neurologist with a subspecialty in Parkinson's.
Which one?
There's the clinic on Commercial Boulevard.
Where do I find one?
Where do you find one?
Yes, with a subspecialty.
Okay, so do you have a neurologist in New York?
No, except my son is a neurologist.
He's a psychiatrist.
Does that
Our-
neurologist-
Our son is looking for the right person. We live some distance from New York City. But
Okay.
our son is a doctor. He's a psychiatrist, and they had to also take the neurology boards. And I think he thinks he found someone, but he wants to really
Yeah.
check it out.
So again, if you even just by word of mouth asking someone, but also looking on the website, they list their subspecialties whenever you go and say neurology in my area. where you're living. It'll list the neurologists and it'll go into their background and what their specific subspecialties are, if they have one. Some neurologists are just general, not just, but they do general neurology, not focusing more on disease management for like Parkinson's disease, Alzheimer's disease, that type of thing.
Are there any final questions?
Yeah, I'm gonna have to put into the watch. Go ahead.
Yes.
Is this something I can expect to live with forever?
Pardon me?
Is this something I could expect to live with forever, or I could be cured someday?
I'm sorry, I'm just not hearing it well.
Okay, is this something that I can expect to be cured from? Or is this something that I'm going to have to live with and accommodate for the rest of my life?
Okay, so is the question, is there different symptoms that you can expect as the disease progresses?
Nor he's asking, is this something he's going to have to live with forever? Or
Yes, Parkinson's disease, there is no cure for Parkinson's disease. The plan is, though, that we manage the motor and the non-motor symptoms that you're having. That's why the individual plan is so important, so that we can get you to at least the most optimal level of living that we can with that. And people have been very successful with that, but there is no cure. A lot of research going on, but at this time, there's no cure.
Where do I start? What should be the first thing I do today?
The first thing you do today,
Yes.
first thing I would do today is call your doctor in New York and get set up for an appointment with a tell them that you really want to see a neurologist has a subspecialty in Parkinson. Maybe he does that you're seeing. I mean, I don't know, but that's what I would do. I know you're going back to New York in 2 weeks, but
No, that's me. That's me. I think this is a different gentleman.
Yeah.
oh, I'm sorry.
No, I live up in Poughkeepsie. I'm not going down to New York.
Okay, so what was the question again?
Basically, where do I start? I live in Poughkeepsie.
Okay, where you start is that you reach out to, you can do it through your primary physician. You can tell them that you want a referral to a neurologist and you want that neurologist to have that subspecialty in Parkinson's disease. Now, when you go to a primary care physician, they're going to be able to actually do an examination also and be looking at the type of symptoms that we talked about with the motor and the non-motor symptoms associated with Parkinson's disease. You know, they may say to you, I don't know, but they still would refer you to that neurologist. But that's what I would do. If they told me that they thought, you know, I thought I might have Parkinson's disease, first thing I would do is be calling a neurologist that has that subspecialty.
Wow.
And I'd be on the internet looking for it.
Is on Commercial Boulevard. Does it have a name?
Is there a name for the facility on Commercial Boulevard?
It's called the Parkinson's Association.
Okay, it's like what they have in New York. Also, is there a phone number for that, or?
I don't have that number, but if you go on the website, just type in Parkinson's Association Commercial Boulevard, it will come up
Okay, that's very helpful.
immediately. You're not going to have to search.
Okay, terrific. Thanks. That's very helpful. I'm also the anxiety, I think, is from the projection of, like the gentleman said, you know, you have to live with this the rest of your life. I know people who have this at this different stages, and it's very daunting, you know, to think of. And how often does it morph into like a dementia or Alzheimer's?
Sure. And, you know, people progress at different levels. Some people never progress past maybe level 2 or 3. You know, it's so individualized. So that's why it's so important that the we're managing the symptoms that you're having with that. And it is stressful and anxious. I mean, I totally understand that, how anxious that can be. And you're always thinking about it and always wondering, and you want to do, find the best care that you can get. And so my recommendation again is to seek out a neurologist with a subspecialty in Parkinson's.
See,
That
my,
would be
my,
a great
And I-
start.
Can I just interject a minute?
Yes.
That I think when you asked what to do today, get up, walk, move. When I was first diagnosed, I have a friend who was very severe, but his wife said to me, first you're going to think about it every hour of the day, then every other hour, then once a day, and then it just get on, just do everything. And movement has been making all the difference in the world. And I think that's the most important thing. You'll get medication rolling. It takes a long time. People have helped me. It takes a long time for that medication to even everything out, get the right dose. But once I was always very active before, but I'm back to golf. I'm swimming. I'm walking. I'm doing everything. So just good luck. But that was the best advice I had. Just get up, go out, do, and little by little, the voice thing is what I have now, is to just you'll stop thinking about it every hour. And that was the biggest change that came. But finding a doctor was very difficult down here. It took 3 months to get an appointment. I have to say that. But so I just say good luck. All right. I have to go now, but thank you very much. Okay.
Thank you.
Bye-bye.
I know we're approaching here on the hour here, so I just wanted to say thank you to everyone for the interaction and the questions with Nora. I think it was a great discussion. And thank you, Nora, for taking the extra time here to talk with everyone and individualized as well. It's really appreciated.
Yes. I hope somebody can
Thank you, Nora.
have a takeaway.
You gave a
Thank you very
wonderful
much for the information.
presentation.
Thank you.
It was excellent. all
Thanks
your-
very much. Thank
You're
you.
welcome.
Thank you all.
Have a
Thank you.
great day, everybody.
Thank you.
And like the other person said, get out there and move.
Mhm.
Yes, keep moving.
Okay?
Yes, you're good, Nora. I'm gonna end the meeting now. Thank you, guys.
Thank you.